Our next speaker is Michael Andor, whom you probably know all, who is talking about the SCQM, but I guess you're talking about some visions about the SCQM today and what the SCQM will be going towards to, no?
So something completely different now, as Monty Python would say. I was prepared to hold my talk in German, but I think I do it in English. So perhaps my English is not that fluent as yours, but it will manage. SCQM is that okay with the microphone? SCQM is not a drug. SCQM is not a molecule. SCQM is not so sexy than the other talks we heard. But SCQM is very, very important for rheumatology in Switzerland. And the upper title of this talk was from research to clinical use, and that's something that we experienced very much with SCQM. SCQM started 1997. It's a very old register, one of the oldest that we have in Switzerland that is still active, and it evolved from a researcher's tool to a clinician's everyday tool that he uses to treat and to talk with and to decide with the patient. And that's something very important. We know that from research with drugs and substances, but that's something that we experienced with a register database now. I have to click here. Yes. That's a picture that some of you perhaps know. The youngers don't know it anymore. The paper, patient history, that's something that will end. We are in the transition to digitalization now, and these paper burdens that we carried around, that's something that will definitely end. But it's not that easy. We have the electronic patient dossier, the EPD in Switzerland. That's the digitalization of your patient record, accessible for the people who need it. You put in there everything of your medical history, of your illnesses, of your vaccinations, of your drugs, and everything should be there. And if you see that's the whole story of the electronic patient report, that does not exist yet. It should be already here, but there is delay and delay and delay and delay. But the idea was you have the patient here, you have all the people around who treat the patient, who make prescriptions, who do treatments, who do radiographs, interventions, whatsoever. All is in here, and all the data is stored in Switzerland, decentralized, safe, but everyone still has access to the data. It's very beautiful. It's absolutely beautiful. If that works, that would be perfect. Everyone knows everything he needs to know about the patient, and the patient itself has the control over his own data. But it's a usability problem. The idea is perfect, but if you have data safety, if you have accessibility problems, if you have privacy rules that you have to fulfill, you have a usability problem in the end. The problem is not here and here. The problem is in the end here. If you fulfill all the restrictions or the laws that has to be fulfilled, you end up with something like that. If you look inside of this electronic patient dossier, you will find something like that. Yeah. There is much of data, and there is interesting data in there, and perhaps it's really all you need there, but you won't find it in this situation, and even if you try to keep it a little bit nicer and with meta tags or whatsoever, it looks better, but you still don't find the information you need on your patient. Looks nice here, but if you look inside, it's chaos. It's not better than the situation that you had in the old days when the patient came in your Sprechzimmer, and he brings you all these clusters filled with history, or he comes in and says, "Oh, I forgot to bring the things." It's the same, just in digital world. So, what would make a difference? The difference is usability. If you don't have the usability, you don't have access to the data in a timely manner. And that's something that we already have in rheumatology. We have SCQM. SCQM is, if you want so, the EPD of rheumatology, still working, still there, or already there for rheumatology. Not the whole medical history, but the rheumatologic history. We have it already, and more. The point is, if you want to work with data, you have to have complete data sets. If you collect something here, something there, you don't know what you collect, and you can compare it with different time points. So you have to make an effort if you want to work with your data and if you want to share data. We have it here, what we really do in SCQM. We have the radiographs, we have the medications, we talk to the patient puts in his own changes and his disease activity, and the effort is very great to collect all this data. It needs work, and a little more of work that we normally do, of course, but we get the payback. It's also important to note that digitalization is unstoppable. The electronic patient dossier at EPD, it will come sooner or later with problems or with less or more problems, but it will come. And if we don't have solutions here with that can be connected to the EPD, others will be there and do it for us, and we have to pay for that then. So you see here a scheme of the EPD, and it's already thought that these apps and applications, they will be linked to the electronic patient dossier. So it will come, and it's better to have our own solution that we can work with than another solution that has not the usability that we need. So, as I said already, we have it already. We are only not connected to the EPD, but a digital solution in rheumatology exists already in our hands. And here we are very much ahead from other specialties in Switzerland. I don't see really much others who are so far with their databases, not talking about research, but talking about daily clinical practice and research together. What we see here, for those who don't use the SCQM, which would be a pity, especially the young, we have to use the SCQM, it's very important. What you see here is the overview that you work with the patient. You see activity levels, you see which medication he had, you see his adherence to medication, you see how medication is related to disease activity, and you see in the time running which medication he had, which medication had a problem perhaps, and you see here what the patient sees. That's my SCQM. He's directly linked with his handy to the SCQM database where he can put his medication, change his medication, put his activity level, and have a look himself at what the disease is doing. And that's a screenshot from my own screen. I have a huge screen, of course, but you can do it also with a smaller screens. You do a split screen whatsoever. And I have at the right side, I have always my patient record. I see the history passed. I see the actual consultation, and I've always a second browser open to the left, where I have the SCQM open. If I start my computer in the morning, I start my PIS, my electronic Krankengeschichte, and I start the second browser with the SCQM on the left side. And if I talk to the patient, he sees my screen, and we make the decisions. We look at the SCQM. I see, well, we did that and that. The activity was so. We make the decision together with the SCQM data board. And if I put in things, medications, it doesn't matter for me if I put it in here or here. That's one. And it doesn't take so much work if you have planned it like that. Do it together, not doing the SCQM later on sometimes, but do it at the same time when you see the patient. So that's what we have, and that's how we can work with it. But the question now was a little bit how does it go on? What are the new shores? Where is SCQM going to? I think 3 words are very important for the future of SCQM. That's usability, as I said already. It's quality. We have to prove our quality against the Krankenkassenbehörden, also all that. And we have to have the connectivity to others. The ship we are sailing on is now database 3. That's the new database that started this year. We had database 2 before, and it started this year, database 3. Most of you find it perhaps a little more difficult to work with it. It's 1 or 2 click more, but in general it's the same with new opportunities. And it has a higher safety level, and it's a little bit prepared, or it's much more prepared to go to the future and fulfill these needs that we have with usability, quality, and connectivity. We have more diagnosis now. The amount of diagnosis is increasing. You know, rheumatoid arthritis, spondyloarthritis, psoriasis arthritis, but it's new that we can now include also, or should include also, giant cell arthritis and PMR. More to come. Perhaps osteoarthritis can be the next thing that could be included into SCQM. I think it's very interesting. These diseases, the bundle of diseases is growing here. We can literally include what we want if we in the rheumatology community think that's an important disease to have a register. It's also for economics, health economics, SCQM is something very important. You see here the goals of the Gesundheitsdepartement from Mr. Berse, the strategy for 2030. Very important points for him is using health data and health technologies. Rheumatology, we are in, SCQM. Increasing quality of care, targeted disease plans, we are in SCQM. Strengthening health literacy, my SCQM, the patient who has his iPhone or his handy, where he is in control of the diseases, where he sees his activity, where he can put in medication, where he can put in, if he does not take a medication, where he is involved in his treatment. Rheumatology, we are in with SCQM. Usability. I think the usability of SCQM will much more increase in the future. One step that we are working on now and planning to do is, you saw my big screen before I showed you, and one idea of course is bringing this SCQM into my patient record electronically. Not having to open 2 things, but perhaps pushing this button, and the SCQM plops out in my patient record directly. Not that much of future stories. We are working at the moment there to do the first steps. First would be the button and another browser pops up. In a few years, perhaps, it's really in the patient record. And that makes the usability much, much better, and more people will use it. Of course, also interface record. If you have things that bother you in the daily work with SCQM, come to us, ask us, say what would be better. We are always have open ears and are always happy to make things better, because for us it's important that's easy for you. Connectivity was the third word. Connectivity means down here we have the SCQM, and in the old days we see SCQM as a database. It's the big SCQM. We put in data. We use it in rheumatology. It's SCQM. But in the future, SCQM will be one of different databases and data storehouses that collect data and put it into this middle layer with interconnected other databases, and we have all the possibilities of exchange of data to put in or to get more information on a patient that we have from other databases, comorbidities, other medications whatsoever. Things come together and we can plan and ask for and solve questions with a totally other new approach. The problem will be, as always, if you have an IT project, it's always the ID. Also with the electronic patient dossier, it's always an ID problem. How do you identify a patient or a healthcare professional in the electronic patient dossier? And it's the same problem here, or it's the same challenge to have an ID that is for all the databases the same. It's easy to have an ID in SCQM, a patient ID here, but to have an ID which is the same patient in the different databases, that's the challenge. Perhaps we get a solution from outside, from the APD, but we will see that. But that's also connectivity. And an interesting point is also that we are used to, as rheumatologists, to feed database, the SCQM database, to put in data. But in the future, we will also have, not going to details of the shim, but in the future, we will have the possibility, perhaps, to have data coming into SCQM from events that happen at the emergency department, an emergency hospitalization of an acute inflammatory state, and the data does come from the emergency department or university hospital database into the SCQM if we have a patient in there. So there will be other sources of data that will fill SCQM in this context of connectivity. It will not be anymore a standalone database only isolated for rheumatology. So, what will come in the future? And I think that depends really on us. Will we have this tree that was planted in 1997 and has been growing and growing and ending up in the desert dead? Or will it be an even bigger tree, giving shadow, giving us comfort, and giving us the possibility to answer questions? And the question, will we arrive here, will be how we work with SCQM. Do we feed this tree with water? And water is patient records. We have to feed SCQM with our patients. Also the researchers, everyone will depend on our daily work with SCQM. So I hope you are already happy with SCQM. I hope you will be even happier in the future with SCQM, and I hope you put all your patients in there. It's worth it, and I can tell you, for those who don't do it, the patients, they like it. They like it really much to work with you on the screen. They like to put their data in the SCQM, and they're not happy if you don't have a look at your data when they come and they fill it in. Doctor, did you look at my data? They like it. It's worth it. Thank you.
Thank you very much, Michael, for sharing your vision and for your infectious enthusiasm.
Thank you.
Are there questions from the audience? Is everything clear about SCQM? Maybe one comment, which is also a question. So in the hospitals, we work with different systems, as you know. We use KISS, others use KISSIM, and so. And so you portrayed the SCQM as an option, as a perfect EPD. So a patient file that could be used every day, just instead of actually what we do every day in KISS or in KISSIM. Is that actually a possibility that this could be integrated or linked in such a way that all your patients that you see in the outpatient clinic or in the clinic are fed directly into this system?
I think it will, even for an RA patient, it will never be the other place to put the data. Or to put all the data. It's complementary. It's surplus. You put there the specific things for the treatment. Perhaps to explain it how I work. If I write my things in my patient record, but for the status, I write it documented in the SCQM, and then I go there or have my PDF record. But it will never be possible in the SCQM to have the possibilities for that has a PIS. Even with all the other data you have there, it's not a repository for the other things you need in the daily practice. It's very specific.
Just the essence you need for management, no?
Yeah, right. Yeah.
Okay, if there are no further questions, then thank you for your attention, and we conclude the session on time.